So our next speaker is Kimberli Davenport. Dr. Davenport is a clinical territory manager for the greater Los Angeles area with Cochlear Americas. She provides clinical and surgical support, as well as training and guest lectures for hospitals, graduate programs, clinical and educational audiologists, and other educational professionals and hearing care. She's been providing those services across the state of California since 2015. She was territory manager for a hearing aid manufacturer in 2011. Going way back, she worked in a school system in 2004, specializing in pediatric cochlear implants, hearing aids, and FM/RM hearing aid technology. Kimberli is very passionate about improving access to care and improving outcomes, and therefore continually trying and failing at work and life balance. Okay, a hot day at the beach with swimming and sidecar donuts is the perfect day. Please welcome Kimberli.
Thank you, Kathy. I didn't go to any fancy schools, so I didn't put that in there, but I've good morning, everybody. I'm Kimberli Davenport. You may remember me from such blockbuster hits as last year's conference, or maybe I've been haunting your clinic for the past 15 years in one way or another. So I'm always excited to get a chance to talk with you, to learn more, and for all of us to continue evolving. Ever since I, was a baby audiologist, I was so excited about cochlear implants and what they can do for people, the way that it can really change the quality of life. And I've hyper-focused, my career more and more into cochlear implants because I still love them so much and there's nothing else I want to do. And also really excited just with the through lines of these themes of, patient-centered care and empowerment. And we're going to talk more about that today. So what I'm talking about, even though my financial disclosure is that, yes, I am an employee of Cochlear, we're talking about a lot of really generally applicable information today to, help us move forward and give our patients really the very best care and outcomes possible. So, like I said, we've been talking about these themes of empowerment, and we're going to continue with that. I loved Dr. Helming's talk, and last night with Dr. Ramachandran. They really highlighted so many important things that we can all do. So we'll continue that, and really all of you being here to continue your professional education and continuing to evolve how you are practicing is really transformative. So I applaud all of you for taking this time on your weekends when I know how busy everyone is to think about how we can be the best we can be for our patients. Now, our mission is so important. It really is at the forefront of all we do, but I thought that, honestly, there's no better example than hearing really from a patient. So since I was not able to have somebody join us today, I wanted to start by sharing the story of Nancy.
My name is Nancy, and I live with my husband, Dave, in Appleton, Wisconsin. My dad bought an organ when I was about 6 years old. I had to take lessons, of course, and he told me someday you'll be glad that you know how to play. As I got older, I would go and play at the county home for patients. And I remember there was a fellow and he'd come waltzing around, and tell me how they used to go out at night to the Cinderella ballroom and dance. In 1977, I followed the instructions of getting an ultra-power hearing aid. Hearing aids work wonders for a lot of people, but with my profound hearing loss, I was pretty much just getting by. I hit rock bottom on November 20th of 2012. The audiologist tried another ear mold. It was whistling. And he said, I don't know how many more times I have to tell you, there's nothing more that can be done for you. It's your life. you have to accept it. Right after that time would have been Christmas, and I was just existing. I think what's the worst is when you see your family feeling sad for you. I just couldn't take it anymore, and so I became a recluse for 9 years. January 17th of 2013, I asked Dave to call an audiologist's office, and she says, "Have you ever heard of the cochlear implant?" She saved my life. I got an appointment and I talked to Dr. Friedland, and he told me, "You do a cochlear implant on your right ear." And I didn't want to sound disrespectful, but I said to him, "This has been dead for 36 years. He goes, "Well, yeah." He says, "You'll hear." It gave me hope. It was 1 year to the day that I had totally given up, that I had my first cochlear surgery. It transformed me. It gave me my life, but it also gave me back to my family as well. Having both implants, my life opened up, and they make me feel young. I had my N6s for 9 years. I thought they were the cat's pajamas. The N8, it was so easy. Came to the house ready to wear, and I put them in, could tell the difference right away. And I thought, wow, that's a magnificent feeling right there. The N8s connect directly with my phone. I can listen to music, and it has an app. You can control the volume and the treble and the bass. Then I kind of thought about it, and I thought, I wonder about my piano. I never thought I was ever going to hear that again. So I put on the forward focus and started playing. I thought, holy cats. My grandson, when he started playing the viola, it's gorgeous sound, and I'd always tell him he was helping me with my music rehab. And he did. My life has been completely changed by my cochlear implants. If it wasn't for them, I would just be existing. I put my cochlear on and I forget I have hearing loss.
I still get really emotional hearing people's stories, and honestly, Nancy is not a unique outlier. Her story and the things that she shared are things that, those of us working in cochlear implants hear quite often, to be honest. I mean, I've heard you guys save my life 3 times now in the past, couple of weeks from patients. And I see so many things with her story that are exciting, and ways that we will, kind of talk about how we can frame our counseling, how we can really talk with patients to meet them where they are and help them make sure that they do, understand what their options are and how they can, how they can improve not only their hearing, but other aspects of their life for better quality overall. So, despite how busy all of our cochlear implant centers are, always needing new and more cochlear implant audiologists, miniaturization of external processors, we've got, excellent, evidence for reliability and safety, and yet we still see very low utilization, not only for those traditional patients, but now with all the expanded indications, thinking about SSD and Medicare expansion, that brings that utilization rate down even lower as far as the people that could be benefiting and either don't know about it yet, are not ready to move forward. So there's so much work that we obviously still have to do, because this number has not changed in 20 years. And yet so much has happened to evolve, the technology, the outcomes, the ways that people connect. You saw everything Nancy was doing with her phone, and I loved seeing how she embraced everything that she can do, and especially getting back to music. So why hasn't this number changed over the years? Why are we still, reaching the same number of people when, we have 11,000 people a day turning 65, and hearing is one of those top 3 health issues in their lives and concerns? We definitely continually hear from, providers when we have these kinds of workshops, fear of surgery, just uncertainty about what their outcomes might be, that fear of loss of residual hearing. And there's, other barriers, even just through the pathway. There can be so many appointments to get to that cochlear implant and that evaluation even. So the pathway is not always clear. Sometimes when patients get referred back to their regular ENT or their PCP, they are not then connected to a cochlear implant surgeon and audiologist for the appropriate evaluations. And so sometimes patients can get stuck in a loop or lost to follow up as well. And, in general, we have, larger barriers too, like, audiology bottlenecks, where you've got kind of longer wait times to get in for either the clinic or to surgery. We see, certainly around Southern California, we can see wait times of 3 to 6 months sometimes for surgery. And on the pediatric side, we also see a very long process at times that can be complicated and have those initial barriers to getting into those physician and audiology appointments. So the more, so what do we do? How can we fix this? Some of the patient barriers that we, have and talk about with cochlear implants are not unique to cochlear implants, and you experience them with your hearing aid patients all the time. You have people who, psychosocially and just emotionally are not ready to accept, where they are and what they need. They might be, I liked what Dr. Helming was talking about with, kind of being able to reframe your own mindset. And while I've gone through that journey myself as well, and I can't always choose happiness every day, but it's definitely something that when we do get into those negative thinking patterns, that we do have to try to reframe things and get into that mindset of what can we do and how can we improve. So that patient journey can be long for some patients, and it can encompass different kinds of devices depending on that level of communication need and difficulty. This process can be longer or shorter for those patients. And so a lot of what we're going to talk about today will be applicable, throughout that journey. So, we know even for hearing aid patients, sometimes it can take many years for them to take that first step to getting hearing aids, and now with over-the-counter devices, that may be opening that pathway more for some people. But, we see across that journey how much people are impacted as their hearing continues to change. And, like Nancy talked about, how that impacted her family relationships, her social relationships, and her overall enjoyment of life. So the more that we can even just think about cochlear implants as part of that overall journey and not the last resort, that's one first step that we can take in reframing how we talk about that, and making sure that patients are aware of cochlear implants earlier in the process, so that it's not a surprise when they hear, after they've had profound sensory neural hearing loss for decades, that, oh, did you know about a cochlear implant? I mean, can you imagine if, having that audiologist say to her, there's nothing, how many more times do I have to tell you there's nothing more I can do for you? I mean, if you've got a pathway of putting a patient on a hopeful pathway or a depressing pathway, that was certainly a direct pathway to depression and isolation. Above the hearing benefits of having appropriate amplification technology, there are so many other health benefits. And, we certainly have seen a growing body of evidence regarding the help that we can see for our cognitive ability, balance, risk of falls, that overall health, and improved verbal and memory functions. So, helping patients, I think part of that empowerment process is helping patients understand what else they, how hearing contributes to their overall health and quality of life. These results were first presented by Dr. Frank Lin and Dr. Joseph Koresh on July 18, 2023 at the Alzheimer's Association International Conference in Amsterdam. So their key findings were that in older adults at increased risk of cognitive decline, hearing intervention slowed down the loss of thinking and memory abilities by 48% over 3 years. I mean, I don't know about you, but like that's frightening. You know, for me as a woman of a certain age, with think about some of those fun things that we get to experience, like menopause, just the aging brain, multiple COVID infections, other health issues. These are things that can already have other impacts and risks. And so, but then we think about how much more important being able to treat the hearing is to help keep that healthy aging brain. So then, when do we consider this cochlear implant evaluation? How do we talk with patients about it? What is the information that you need to have to counsel confidently and meet patients where they are, so they have that informed decision-making, which is also part of that empowerment. By engaging patients before their hearing progresses to the point of needing, to where they, I talk to people often where they say, yeah, for my patients that are in power hearing aids, if they get to like 20%, then I definitely think it's time for them to consider a cochlear implant evaluation. By the time they are reaching that point, their overall potential has decreased. Not only that, but as patients age and they have additional health concerns and issues they may be dealing with, their own ability to safely access surgery and general anesthesia may also change, or their priorities for which health conditions they need to focus on can also add additional barriers. So when we think about and utilize the guidelines for that have been developed, and I'll talk about some other new information too that you can use within your practices, helping patients understand the importance and the impact of seeking out that continued journey earlier on in the process can have a big impact on their outcomes and continued connection to their world. So, just putting that really simply in another way, the patient A is likely going to do much better with a cochlear implant than patient B. Patient B likely has had a longer duration of hearing loss, and that already is one factor that contributes to overall outcome. But we also know that there are some additional benefits when there is some residual low frequency hearing, for example, and when they're able to even be bimodal, having one hearing aid, one cochlear implant adds additional benefits, and then of course going to bilateral cochlear implants if necessary. The more time that is lost, the greater the consequences for that patient. We think about things like, again, that mental sharpness, loss of enjoyment of life. The harder communication becomes. I think we've all heard from hearing aid patients that they're no longer able to go to church or understand. Maybe if they go, they just know they're not going to understand anything. Maybe they're trying seating arrangements, or they aren't really able to socialize afterwards in ways that were really meaningful to them. The ability to work. I've also seen patients who, across many different professions, from physicians to, police officers, all kinds of different professions where, as their hearing loss progressed, they lost their ability to work, took early retirement, so those are, big financial impacts potentially as well, in addition to how that affects people emotionally. The balance and falls is big as well. That loss of independence, again, so when we're thinking about empowerment, I just think about how, Nancy said, I had Dave call an audiologist. So, you've got a patient who no longer is able to make phone calls on their own, make their appointments, connect with people in that way. And then the frustration, of course, you think about trying to have a family dinner where you've got 10 people at a table, you've got grandchildren with higher pitched voices. Again, things that can really bring joy as we go on in our lives. We should be able to enjoy retirement, enjoy our families, and, as just humans and patients. So what kind of information then can be helpful for them to understand, pulling in those other health benefits and talking, really, asking them what are their goals, what are they looking to achieve. Jamie, my colleague Jamie, and I were talking a little bit earlier too about some of the challenges that can come too from waiting, the longer that they wait, and as they age. I will talk a little bit about outcomes and the differences that we see in those older adults versus a slightly younger subset. And I do see a lot of people really embracing their health as they are getting older. They are, we're changing our diets. We're trying to, get ourselves healthier without medications, or, just doing the things that we can to stay as functional as possible. And this can just be a natural part of the conversation. So evidence does show that people with cochlear implants do see those improvements in verbal memory functions. Delaying implant care can certainly impact that. And one of the things that we offer, and I think you can find with, as we can see with the previous speakers too, hearing aid and cochlear implant manufacturers have really done a lot of work to develop those resources to support your conversations and support the patients in their additional research and conversations to get through that process. So, things like this are resources that you can have to show, to refer to. The current guide is there anybody here? Well, who here is familiar already with the 60/60 CI referral criteria? So this is not from Cochlear. This is actually developed by Dr. Terry Zwolen when she was at University of Michigan, and they did a retrospective study of several hundred patients over time to look at how do unaided word recognition scores correlate to patients who meet cochlear implant candidacy. And what they determined was that 60, so if their pure tone average is greater than, their unaided word recognition is 60% or poorer, and also considering their PTA of 60 or greater, then that would definitely be the time to discuss candidacy evaluation and helping them look at that next step. Now, while those numbers are, they're guidelines, those are guidelines, but, we're thinking about our whole patient. So we also need to really be listening to them and thinking about what are their struggles, where are they having the greatest challenges, because you might see a patient who does have, one thing we can hear often from providers is, well, I can fit this loss with hearing aids. And that reminds me of Dr. Ramachandran's talk last night, where, sometimes we have to get away from thinking what we can do as providers and really what is the need of our patient. How can we improve that patient experience? And just because we can fit a hearing aid, it is really important to understand what is the benefit the patient is getting, and is it enough? So their study did determine that 95% of patients who met the traditional indications for cochlear implant had a pure tone average that was greater than or equal to 60 dB. So they didn't pull it out of the air. And 92% of those patients who met traditional CI indications had a better ear unaided monosyllabic word score that was less than or equal to 60%. Does that surprise people that an unaided word recognition score of 60% would warrant further evaluation? So I think a lot of people think, hey, that's not bad. You're doing pretty good, when really you think, wow, unaided, they're still barely getting half of the words. And that's in quiet. And that doesn't account for how they are doing aided, so what their aided speech performance is. So over the last few years, we've seen major expansions in candidacy, insurance coverage, and a growing body of evidence to support cochlear implant for these updated indications, whether it's, pediatrics having that indication of 9 months with cochlear, trying to get them implanted before the age of 12 months because the outcomes are so much better with that group than with older children, CI for SSD. I'll talk about how much coverage there is for patients there and what cochlear does to support clinics that are working with SSD patients. That CI for SSD is approved down to 5 years of age for children, although we do see some approvals at younger ages because, again, there is such a body of evidence showing the difference in outcomes for children that are born with that profound sensorineural hearing loss, and even if it's on that one side, if we wait too long to catch it, it does impact that outcome. The Medicare expansion. So previously, while everybody who didn't have Medicare could meet an aided sentence score, in the best aided condition of 60% to qualify for a cochlear implant, Medicare recipients had to meet a criteria of 40%. So there were a lot of people who certainly were struggling but could not access cochlear implant with Medicare. Now, since 2022, that's changed. Now everybody has that same criteria of the 60% in that best aided condition. And I'm going to talk a little bit more soon about what does that best aided condition mean and how have our own guidelines updated recently for evaluation and protocols. We talk a lot about indications and candidacy, and that we can see these words used interchangeably, but with an indication, we're really talking about what is that guideline based on that audiological criteria, that speech perception data, whereas candidacy is taking your whole patient into account. What are their goals, their needs, and they're so much more than numbers. So, we think about those factors to consider, like expectations, insurance coverage, age, health, motivation, family support, cognitive function. There's a lot to consider, and there are a lot of ways that we can tease out that information and have a much more comprehensive picture of the patient's needs and goals. We utilize something called the MSTB, the Minimum Speech Test Battery, and that provides the recommended testing protocols, testing resources. And these guidelines are developed by our thought leaders in our field in this country. It includes the leading surgeons, audiologists, all the CI manufacturers participate in this as well. And this is now the third iteration of the MSTB because, of course, since cochlear implants first came on the scene, 30 plus years ago, things were very different back then, not only in terms of which patients could qualify, but what those outcomes were because of, the limitations on who was eligible. So over the years, as patients have really expanded into what kind of patients we're seeing as the outcomes and technology have improved. We've seen this need to evolve. The last iteration was updated in 2011, and because the prior testing recommendations had too many ceiling effects because patients were doing too well now for those original test considerations. So, that's when that AZ Bio came into play. And now with this latest iteration, there's really a big goal to better standardize across the cochlear implant field to ensure that we are all working from those same definitions. We share the definitions and terminology and a standardization of evaluation protocols so that no matter where a patient is evaluated, if they're a candidate, they're going to be a candidate no matter where they go. It's not they go one place and they're told no, and they have to go seek a second and third opinion to find out that they are, in fact, a candidate. So the more that we can work from this standardized base, again, that's going to improve the experiences for patients, and it makes it honestly easier for us as professionals to have these guidelines and standardizations. So some of these changes, we see that, best aided refers to the ear to be implanted now. So we used to talk about best aided, some people defined it as 2 hearing aids. Some people defined it as, whatever the patient used in their everyday life. Some people took it as that ear to be implanted. Having a standard definition of best aided is important. And there's also more of a focus on those CNC words for an initial clinical consideration of who would be a candidate to do further testing. However, most insurance companies are still really using the sentence scores to qualify patients for insurance coverage. So we have a level of clinical candidacy, and then, we look at that insurance authorization, eligibility as well. But I think it's important for patients to know that they're a candidate, whether or not their current insurance approves their device. Insurance does not determine who's a candidate. They just determine what they will cover. So having another way to empower patients is to provide this, more comprehensive information to them so that if they have other resources and want to pursue other paths, they can do that. For some patients, that might mean changing insurance if possible. For some patients, that might mean, pooling their own resources and funds to go forward in a self-pay type of situation. But again, it should be up to them to make that decision and not just for us to hold back information because of the particular insurance that they have. What they can be told is, we can do this evaluation. You have Medicare, they don't currently cover, this particular indication. However, you are technically a candidate, so whether you want to stay with your insurance, whether you might have other options, that's a further discussion. Now, there's also a further comprehensive resources with the MSTB3, including the recommendation and access to cognitive screeners, like subjective questionnaires. Sorry, you can't get the cognitive screen through MSTB, but there are those questionnaires which, again, can really provide so much information, especially when you're looking at a patient with SSD. You may have additional considerations of tinnitus, so wanting to assess, what is that THI, tinnitus handicap index, looking at the SSQ to find out more about their overall needs, outcomes, functioning. So considering adding these can really further improve their overall experience and the information that you're working with to make your clinical decisions as well, and uncovering who they are completely. Now, the missing component is an objective validation of that speech understanding for hearing aids. So I'm going to talk about that in a minute. Unless that speech understanding testing is done in an aided fashion with their hearing aids, it's really hard for us to know for sure how they're doing and how we can predict what they need next. So I'm going to share, and I am going to share a PDF of the slides afterwards, but I'm not, the next couple of slides will not be included because, again, I don't have, it's not my place to distribute somebody else's study, but I think this is really, really important information to share. If you're familiar with Dr. Mary Rose Goldstein, she is the lead audiologist at the Center for Neurosciences in Tucson, Arizona. And they've been really interested in that topic of how can we utilize the MSTB3 for an additional validation measure for hearing aid patients to better assess how they're performing with their hearing aids and what their needs might be. She presented this at AAA this year, and you can definitely, I think, get a hold of her information through that. Her talk was excellent, and we're very excited about what their group is doing. So let me go back up. What she saw, what they looked at was their group did a retrospective study of 637 ears, 353 patients, and these patients ranged in age from 20 to 71. 20 to 90. I think the median age was 71. It was about half males, half females, and they looked at those patients who had an unaided, that PB Max score that was obtained under earphones at UCL minus 5 dB. And they also had that aided word recognition score using the CNC, the test, which is available through the MSTB3 site. Utilizing that, the CNC was administered at 60 dBA in the sound field with appropriately fit hearing aids that were meeting VeriFit targets, NAL, NL2 targets. Those patients had an acclimatization period with their hearing aids of 1 to 3 months before that aided speech perception testing. And what they did then was they calculated that unaided PB Max, subtracted the aided word recognition score, and what they were looking for was whether there was a speech perception gap between their unaided recognition and then their aided performance. So, while we really rely on aided speech perception testing in the cochlear implant space, for many years now, it's really been that real ear verification that's kind of, been the gold standard. And, how many of you do routinely do aided speech perception testing with patients in their hearing aids? Okay. Yeah, so, it's great to see that it is happening in some practices, and I think the more people that do consider adding this in, again, the more information you're going to find. The literature suggests that up to 20%, about 20% of people will have a speech perception gap. And what their group saw was, they stratified that data by their PB Max scores, and there was a clinically significant speech perception gap in about 18% of those patients, 116 out of those 637 ears, and those were the patients that were underperforming with their hearing aids. So that gap was 34 to 37% respectively in those groups. And what they also found was that the patients who had that PB Max between 40 and 80% were at the greatest risk of having a speech perception gap and underperforming with their hearing aids. Is that surprising? I was surprised that it was up to 80%. I think a lot of us think like, gosh, if they've got 80% unaided, like they're gonna do great. But think about, if you are able to identify that gap, we're talking 10 minutes of testing. What if in 10 minutes of testing, earlier on in the journey, you could identify a patient that was underperforming and maybe really needed to consider a remote microphone, that greater assisted listening, communication strategies, whatever that is, you can determine they're doing great in their hearing aids. You may determine they need something more with their hearing aids. You may see that they really need to consider a cochlear implant evaluation as their next step. And, thinking about, also what if you had one test that you're using throughout the patient journey, whether they're wearing OTC devices, hearing aids that you have fit them with, cochlear implants, and they've got a baseline that they've started with that can be tracked throughout their whole hearing journey. Does that sound valuable? I think about, when I was working for the hearing aid manufacturer, when I often got called in to support, it was those patients who were continually coming back frustrated, asking for more adjustments. What else can you do? I'm not doing well. I hate these. Why are you terrible? I'm going to go to somewhere else. And, when truly that extra 10 minutes of testing probably would have identified earlier on and saved them from coming, back to your office every month and a half, or, when you really need to be fitting in some of those other patients. And you don't want your patients to have a bad experience. You want them to do well. And it can be frustrating when you're not sure what's going on and how to resolve it. So this protocol would be, I think again, we talk about how change can be hard for patients. It's hard for us as well, right? It's not always easy to, take the time out of our busy days to think about how we can improve our practice and, what we might need to do to achieve some of those goals we'd like to and make our days easier. Sometimes we do have to put in a little extra work to give our future selves the gift. So if we could improve that patient experience, satisfaction, have them on board with you from the beginning so you can move forward together, being able to determine those needs will help. So, you can definitely, while her patients had that 1 to 3 months of acclimatization, we've got this 45-day period in the state of California for patients to try their hearing aids. So what do you think about the possibility of being able to provide that testing before they have to, decide whether to keep those hearing aids? Does that sound like a possibility? And for those of you then that are, partnering with the Cochlear Implant Center for those referrals, one thing that you can do is be aligned with that Cochlear Implant Center on what is their aided CNC cutoff score. So with that new MSTB3, the centers are choosing somewhere typically between 40 and 60%. I'm seeing a lot of centers choose 50% as that cutoff score that they are looking at to then move to the next step of testing for patients. So just being aligned with whatever center you're working with is important. The number itself isn't as important as just being aligned with the center that you're partnered with. Moving forward then, let's say you've identified that speech perception gap and you're ready to talk with them about what is a cochlear implant, what is the technology like, what can they expect in this regard. So truly, whether you're working with pediatric patients, adult patients, any stage of life, it's changing without my, sorry, I'm having a little technical fun adventure here. Hopefully the slides won't keep changing on me here. So whether they're going to be better served by either a cochlear implant system or a bone conduction system, depending on their, etiology, duration, insurance coverage, there's a lot of things that can play into, especially when we get into things like SSD. Cochlear has a very broad portfolio of, the most reliable, both external sound processors, internal implants, because we're really looking to continue that, removing those barriers, like making things small, light, comfortable. We do still see that there can be barriers for patients around, size, that desire for discretion. People want others to focus on who they are and not necessarily think about their hearing. And, there's so much more to success than great technology. Hold on. I'm not sure if I've done something, but it's moving the slides forward without my my direction, and I'm not loving it. One thing, we're really going to focus on CI today, but I do want to take just a moment to say that, for bone conduction, this is, especially in the pediatric space, oh my goodness, it just keeps doing it. If we look over at your non-surgical devices, then that Ossia system is your really superior surgical system. Thinking about any pediatric patients that you're working with that are in those non-surgical systems, what we see in North America is that while Ossia is now indicated down to 5 years of age, and thinking, oh my goodness, sorry you guys, it just keeps doing it, so I'm gonna just keep going back here for a second until I finish this point. 53% of kids in soft bands are in that 12 to 18 range. Oh, thank you. I just don't want to take a lot of time with it because I know we're kind of running. All right. 1 second. Any questions so far while Gary, is it time for you to do your stand-up? He did warn me he may not be totally safe for work, so maybe we'll keep him at bay for the moment. Has anybody here that is not already a CI provider Has anybody here referred a patient for a cochlear implant evaluation in the last 6 months? Okay. Do you know if they moved forward?
No, it was a pediatric, and once they did the MRI, he was physiological. He wasn't a candidate.
Okay, so it was a pediatric patient, and after the evaluation, imaging was not a candidate. But that's great that you identified them and they at least like move forward to have that evaluation process. Has anybody referred a patient in the last 3 months? Okay. For those of you who are out in private practice, how many of you would say you are referring one patient? One patient a year, 5 patients a year, 10? No, okay. Good, that's really helpful to understand too, just, what are you seeing in your practice and who is eligible. So lot sounds like plenty in the past year and some within the past 6 months. That's great to hear. Thank you. All right. So, regardless, it's truly more than, what is your internal, external technology. There are so many more supports and tools that contribute to success. And, Cochlear is very proud to be that global leader in, not only reliability, but in, developing those tools and services to provide that greater access to care, testing ways for people to access care remotely. We've seen that be really important through the past few years with the pandemic, and honestly, just improving access for people and reducing their need to come in unnecessarily if they don't have to. We think about those lifetime of support services. That baby that is implanted at 12 months of age, we expect to be supporting them for the next 80 plus years through their hearing. And, one of the things that patients often ask is, well, how many times do I have to get surgery if I get a cochlear implant? How does the technology upgrade? And honestly, the hope is that they do have that device that internal device for a lifetime, and that their upgraded technology happens through those external processors. Every 5 years, there's usually insurance approval for those upgraded devices. And then, of course, being able to provide that support, whether it's for the clinics to help outsource some of the equipment counseling, oral rehab counseling, getting them connected to their wireless accessories. When we first all, started having these wireless accessories and direct streaming to phones, all of a sudden we had to become Apple geniuses. And, that's not necessarily how we should be spending all of our time. And so having the manufacturers take on some of that support for you to be able to focus on, the programming, the testing for your patients will hopefully give you that support that's needed. And then, of course, the difference, too, between cochlear implants and hearing aids often is that with cochlear implants, the manufacturer does provide some direct care and support rather than having to go through the audiologist for everything. So, once patients have their implant, they don't call Dr. Williams at UCSD for troubleshooting help. They call Cochlear's device support for help. And, then once it's determined, do they need a replacement processor? Great. So then, we should have that ability with most clinics then to program that replacement device for them, send it to their home. So again, it's, keeping them from these appointments to just pick up a processor and have it reprogrammed. Those apps, those streaming services, the accessories, these are all ways that we can really add in. And having patients be able to call on Saturdays for help too is a big help. One of the things I think that can be challenging if you don't work with cochlear implants is how do you explain what a cochlear implant is and how does it work? And, again, great resources out here to show you and show your patient so you don't have to do the explaining.
The cochlear nucleus system replaces the parts of the inner ear that aren't working. Unlike a hearing aid, which makes sounds louder, the cochlear nucleus system works to make sounds clearer, so that it's easier to understand conversations. It's comprised of 2 parts which work together, the cochlear implant and the sound processor. The sound processor sits outside the ear and can be worn behind the ear or off the ear. The sound processor is connected to the implant which sits under the skin. The implant is attached to an electrode that is placed by the surgeon in the cochlea. Sound is picked up by 2 microphones on the sound processor and sent to the implant, where it's converted into signals that are sent into the cochlea via the electrode and are interpreted by the brain as the sounds you hear.
So having access to a video like this not only will sound very fancy, but for some people having that visual, I'm definitely one of those people who needs not only the auditory information but the visual component too, to fully wrap my brain around new concepts. So this is something that's available on YouTube. Very easy to share with a patient, or even just to help you, kind of get your own talk track together of how you explain to the patient. Additionally, we have, resources like cochlearelectrodes.com, for not only if you are interested in seeing what are the electrodes like, what does the insertion look like. Think about your favorite kind of patient, the engineer. They always want as much information as possible. Typically, once they do get implanted, I've had several engineer patients who show up at activation and they've already got new design ideas for us and ways to, improve everything. And, of course, they want the software to program themselves, right? So, there's resources that you can, again, help get patients connected to just by even connecting them, with the manufacturer, so that we can say, hey, here's some information, We have somebody on our team who her whole job is to connect with patients that are considering an implant. She will sometimes have hours worth of conversations, with patients while she's helping to remove their barriers, understand their goals, and, really help them feel confident. That's her goal, is to get them thinking about what are they going to gain back, what are they excited for, what do they need, and that's part of that changing mindset. So, when we think about outcomes, what do you tell the patient when they ask, how well am I going to do with a cochlear implant? You aren't able to tell them exactly, but one of my favorite surgeons, what she says is she shows them their audiogram and she goes, I can do better than this. So, that's the goal, right? We want them to know that they have the potential to do better than they're doing currently in hearing aids. And so you don't necessarily have to give them an exact number, but we also want them to understand that their outcome is going to be impacted by their own motivation and work. The surgeon is going to do their fantastic job with soft surgical techniques and using an electrode and other, hearing preservation protocols, structural preservation protocols. And really what we see these days is the cochlear implant surgery is, about an hour and a half, 2 hours long. Patients go home, vast majority same day, unless, maybe they're a more medically complex patient. And this is a low pain recovery, both on the bone conduction and the cochlear implant side. We've had a lot of conversations recently. I had a recent in-service with educational professionals, and we talk about how kids that might go through years of ear reconstruction, it's a very long, painful process, and then by the time they finish that ear reconstruction, you talk to them about a bone conduction surgery, and they're like, nope, no more surgery for me, thanks. And, we've really missed opportunities with those kids, and, while they're getting into their most challenging listening environments, when their cognitive load is increasing, their academic, education is getting more complex, they're still in a system that isn't even able to provide them appropriate access for speech and noise, and, listening fatigue is real for adolescents, for kids, for us as adults. So there are studies out there. This is an independent study. This is not from Cochlear. They looked at both CNC words and then that AZ Bio sentences at a +10 dB signal-to-noise ratio. And it looks like both speech and noise are from the front. You guys, I'm seriously losing my vision, and I really need progressives, and I haven't done it yet. So I can either see you guys or I can see my slides, but never the twain shall meet. So on those single word scores with the CNC, you can see that on average there's a big jump in 6 months. average of 46 points. When we look at that speech and noise, again, that's a very complex situation, but we do still see a significant jump in performance. So if even if you're looking at a 20 to 30% improvement over where your patient currently is, let's think about what that could provide. And then we also think about, back to where are they starting from? If they're starting from a place of 40 to 50% and they're gaining that 20 to 30% improvement, that's going to get them up to about, 75% of the words. Whereas if they get down to 10, 20%, and then we're still, seeing that kind of improvement, we're only getting them up to, maybe half the words. So that's where, that earlier treatment can really be critical for that full potential. So, cochlear implants work, there's no question, very well established. But, what about outcomes as patients age? So they absolutely work in older adults. There is no age limit for who can get a cochlear implant. We'll look at those whole patient factors. What's their health, their motivation? Are they able to safely undergo surgery? One of the most exciting topics for surgeons right now is whenever they come back from conferences, I'm like, what did you love? What was great? And they're like, CI surgery under local anesthetic. So that is happening more and more for patients who may not be able to undergo general anesthesia safely. And there are local surgeons who are doing those cases who have a vast amount of experience. The oldest patient I know of who did that in the last few years was a 102-year-old gentleman who could not wait to get back to his daily 2-mile walks. I personally don't want it, but, again, my own bias is not for others, they get to make their decisions. And there are many patients who are willing to do that. So this is a result of the Medicare expansion study, and there's a couple things I want you to notice. These are all patients over the age of 65. The yellow bar is their baseline. That middle bar is 6 months post-activation. That blue bar on the far end is 12 months post-activation. So looking at the AZ biosentences and CNC, again, you see a large jump in their performance. The other thing you may notice is there's not really a difference between their 6-month and 12-month scores, right? So we also used to tell people, it's going to take about a year, maybe more, for you to, kind of get to where you're optimal functioning with your implant. And that feels like a long time. But what we see in the evidence is that patients make their largest jump in performance in the first 3 months after their activation. And what is critical to that is having full-time device use, a minimum of 10 hours a day. Patients who wear their processor for 13 to 15 hours a day see a significant jump in their performance by that additional wear time. Being in speech environments, doing their oral rehab. These are all factors. So that motivation and establishing your patient's motivation is really critical, and it may be something that has to be teased out. I think sometimes with the conversations we have with patients, especially if we aren't sure of some of the answers, a patient, maybe some of you have brought up, who here has brought up cochlear implant to a patient and then they've said, oh, no, I don't want surgery. Yeah. Does the conversation end there? Or, that's one thing we have to think about. Are you willing to probe a little more? Tell me more about that. I want to understand more about this. Tell me why you don't want surgery. Let's talk about it. Just being open to the conversation and leading with curiosity can really do a lot for, getting on that same page with your patient and having them be open to share with you. And again, you're not expected to have all these conversations by yourself, but if you can start the process and just get them open to even talking to another person, what we do see as being one of the biggest motivating factors for patients to move forward is to talk to a recipient, to hear from a recipient that is successful and them being able to share their experience. So while, everything that we do as professionals is important, we aren't the only important resources in this process. So, think about that too as you're talking to patients that, they're going to have an acclimatization period in those first 3 months, but they're really going to see those major gains early on. And that can really be much more hopeful for people. I know somebody told me I need to do 3 months of physical therapy versus 12 months of physical therapy to get results. I'm probably going to be more consistent and be able to follow through and just be more hopeful in general about the situation. And then, we think about older adults. So there certainly are, oh wait, did I miss? No, here we go. So with older adults, they absolutely work for those older adults too, but we do see some different outcomes as people really get into those advanced age categories. So if they are over, if they're above 80, when they progressed from an average of 22% up to 45% by 6 months. So again, if we can get them earlier, when they do have that better potential, and when they aren't dealing with as many other health concerns that may impact their ability to get surgery or their ability to prioritize, can really help. We see that patients really see a lot of benefits over different kinds of situations. So not just, so hearing in groups, talking on the telephone, hearing TV, being able to be in a small group. I do call some of these varsity level skills that we don't necessarily expect them to be great at in those first, couple of months, but they're going to be working on that oral rehab, and they're going to see that continue to improve as they stick with it and their brain gets all that great stimulation. I need to kind of move along, so I want to get into the SSD because I think this is an area where people often have a lot of questions and want to understand better how to work with those patients. We do see it's a good number of patients, not only those children that are born with single-sided deafness, where we're talking about specifically a profound loss on one side versus unilateral hearing loss that could be of any configuration or severity. So we do see about 30 to 40% of those kids that are identified at birth as, having SSD, and then of course we may see a progression later on. When we look at the etiologies that we see for adults, a lot of idiopathic etiologies. There's some genetic, other autoimmune conditions. Cochlear nerve deficiency is certainly an issue, and we are seeing more kids getting implanted with hypoplastic or thin nerve, where, again, this might change some of the expectations. It doesn't mean they don't benefit from an implant, and it's not worth trying, certainly. There just needs to be a nerve to stimulate, of course. But let's move on more. I think we understand the impacts of, to patients psychosocially, auditorily, and for quality of life. So let's talk more about those treatment options and pathway and outcomes that we see. So since obtaining FDA approval for CI for SSD in 2022, over 114 million people in the US, or 68% of the population, has coverage for CI for SSD under 48 different insurance plans. At least when that slide was created. It's maybe more at this point, in fact. So currently, Medicare does not cover CI for SSD. However, if they have a Medicare Advantage plan, we have a team dedicated to obtaining insurance authorizations and overturning denials. That team has an 87% success rate in getting those authorizations. And for the 32 Medicare Advantage cases that have been submitted, there's been a 41% approval rating for those. So again, those plan specifics may be really important to understand for that patient in order to go forward and understand where they're going to go in that treatment pathway. Because whether they, not only their duration of loss may be a big factor in whether they might be eligible for a CI or need to think about, bone conduction or cross. And some patients may do nothing. We know that patients, especially that have had that for a very long time, they've learned to cope, and for some they're like, I'm fine, and there will be a subset that don't go forward. But when we think about what are those etiologies that might lead them down one pathway or another, you can see here, certainly if they are straight Medicare, have that long duration, that's probably going to be more a bone conduction or cross conversation for those patients, whereas that sudden sensory neural hearing loss, or if it's been within the last 10 years, those are often really fantastic candidates. We are seeing more patients who may have an acoustic neuroma resection, then sometimes with simultaneous placement of the CI or potentially afterwards getting a cochlear implant, we can see more variable outcomes for some of those patients. But again, they may still be able to obtain the improvements that are needed for them to function in their daily lives. I worked with a patient yesterday who was born with SSD already, and then in his good ear, he got an acoustic neuroma. So that neuroma was removed, a CI was placed, and the neural integrity wasn't the most amazing. So, honestly, his single word score is about 30%, but without that CI, it would be nothing. And he is able to still teach, teaching physics, and getting by in amazing ways. So, just getting them to talk to the right teams, I think, is really important. For those indications, we're looking at those patients that are 5 and older. They do need to have a nerve. There are these specific criteria for it to be an on-label case. We do sometimes see approvals for patients who have some maybe thresholds outside of that, or it can be different so I think what's important is, we always will talk about what are those FDA-approved indications. Certainly what we see out in the community is that, again, taking that whole patient into consideration, there may be great options and great insurance. So for that treatment pathway for your adults with that, SSD, first you're going to start, with all that history, getting all of their good information. Then we, are moving on to that evaluation. From there, looking at that audiological profile, how are they meeting that criteria? And of course, then getting into that, the imaging is going to be really important. What are we looking at? And then what are the future imaging needs going to be? That may also be a consideration for specific devices, placement of devices. We've all got MRI-compatible magnets now for on the CI side, which is fantastic and has really helped. But occasionally, we still see where there's an artifact or a shadow. So if they need very specific brain imaging for later on, that may be taken into account too. So, after we've gotten them through this process, then for some patients, they are going to be uninterested in considering surgery, and they may be looking at, a cross hearing aid or, doing nothing. Then, again, that longer duration, neural integrity, insurance coverage considerations may lead them down a bone conduction pathway. And then, if they are eligible, we do see really significant benefits of the CI over these other treatment options in terms of localization improvement, speech in noise improvement, having that better balanced feeling, overall quality of life improvement. So that, again, kind of leads you. So when we look at what are those outcomes by option, again, we're looking at that better speech in noise. And then, of course, with bone conduction, when we look at the difference between bone conduction and cross, we do see some additional benefits with a bone conduction system, especially over time compared to a cross. No harm in having them try a cross first and see, are they satisfied? Do they like this? If it doesn't feel enough for them, then they might be ready to think about that next step. What about when we look at that outcome for those CI patients, what kind of improvement do we see? So you can see this is looking at an SSD group versus just a traditional patient group. Very significant speech perception and quiet benefits over the preoperative condition. And then, of course, looking at hearing and noise, too, we see CI gives the best benefit as when we're looking at an SRT improvement, lower is better. And I'm kind of going through this quickly because I want to make sure we can get a chance to get to some of these. I think it might be helpful to review some audiograms and see, like, what do we think of these patients and their potential candidacy. So these are all, in fact, real patients, too. So this patient audiogram, you can see we've got their PTA, so they are in that severe to profound region. Their unaided word recognition score, we've got 60% in the right ear, 20% in the left ear. What do you think? Send them on? Okay. So they did get sent on. When they had their evaluation, their aided speech understanding with that CNC test, right ear, 8%. So, big difference from that unaided word recognition score. Left ear, 24%. And then we look at that sentence testing, 24% on each side. So, certainly hitting that qualification even without having to do any speech and noise testing. In fact, they probably wouldn't be able to do any speech and noise testing with a quiet score of 24%, right? So then, 1 year later, how are they doing? Well, they're doing so well that we can finally test them in noise, and their AZ bio scores at a +10 signal-to-noise ratio is exceeding their, preoperative quiet AZ bio score by a good amount. And of course, when you look at that right CI AZ bio up at 98%, I mean, what a huge difference. So that's one example, so good. Let's look at the next one. Or any questions before? You can feel free to stop me if you do, and I can always repeat the question if we're trying to run to get a mic. So the second patient, the patient meets that 60-60 criteria officially. There are no profound thresholds. We've got that right ear pure tone average of 65, left of 60. And then, of course, our unaided word recognition scores are falling under 60%. So what happened to this patient? So for this patient, once they were evaluated with their own hearing aids that they came in with, and then with clinic hearing aids, what they found was that they were underperforming with their current hearing aids and essentially needed to either look at getting those aids reprogrammed if possible or considering new devices that would be more appropriate. So still valuable, right? Even though, they went on to that evaluation, and guess what? Now they're going to come back to you for new hearing aids. And they now have the benefit of having this initial evaluation and understanding that, hey, even if I get to a point where these aren't working, we can look at something new.
Well, I know historically that you used to have patients wearing hearing aids for a certain amount of time before they were actually implant candidates. Is that still the case? I mean, you have to wear hearing aids, try hearing aids for like 6 months before you?
So the question is, do you have to have patients wear hearing aids for a specific amount of time before they can qualify for a cochlear implant? And, because I think that more centers were really enforcing that. I do still see some centers having some patients do, at least do a hearing aid trial if they aren't currently wearing a hearing aid. But we also see that, most of these patients are already coming in having worn hearing aids. And, you don't necessarily have to, if you've identified their candidate and you've done it with your own clinic hearing aids, and you can see that they're still not meeting those targets, certainly what's going to be gained. And while, maybe if they wanted to try something during a trial period, asking patients to try hearing aids for another 6 months, how do you do that without purchasing them, right? So I think that's one of the challenges of requiring that, and I haven't seen most centers requiring. Feel free to, if you guys have any, you can correct me if I'm wrong. All right. Last one. So this patient, again, when you look at their PTA, it's up 77 in the right ear, left ear 72%. Word recognition for each ear is falling under that 60%. I mean, and honestly, this is probably, an audiometric configuration that you see pretty often. What do you think? So let's see what happened with this one. Once they got that evaluation, you can see that their CNC was very challenged there at 26 and 36%, respectively, and then that AZ bio testing also qualified them in quiet before having to go to testing in noise. But they were able to still complete that in what we would now call the everyday listening condition. So if for that patient, they are typically wearing 2 hearing aids, then that's their everyday listening condition. If you've got a patient that their everyday listening condition was already only 1 hearing aid, then that's something to consider, because remember, best aided is that ear to be implanted now. They did get implanted, and you can see postoperatively they're in both sides. 42% CNC words in the left ear, and the right ear 92%, so really big difference. And sometimes we don't get to see which is the better ear until they're both implanted. There is, the one thing that Nancy, mentioned in her story was that, this ear's been dead for 36 years. She was wearing hearing aids during that time, so that's, she was still getting some continued stimulation, but certainly thinking about if it was dead for 36 years with no stimulation during that time, that might be a slightly different expectation conversation, certainly. And then, of course, in that everyday listening condition, postoperatively, in quiet and noise, they're doing so much better than before. So big, not only that, again, that big hearing improvements, but we're giving them those other health improvements as well. So let's talk, a little more specifically about the counseling piece now. We'll put everything together that we've reviewed and, talk about how do we have these conversations? How do we help them be ready sooner and embrace change? Introducing that CI as part of the patient journey from the beginning. So you're talking to the patient, you say, yeah, there's everything from over-the-counter hearing aids, all the way to cochlear implants as the, hearing and level of communication changes. So just introducing that idea and having them be aware that cochlear implants exist. And knowing that as their hearing progresses, that they don't have to lose hope. For that counseling, we think about, again, change is hard. Change is hard for them. It's hard for us. So helping with that mindset thought. You are their trusted provider, so that's their trusted advisor, really. So the more confidently you can have these conversations, you don't need to know all the answers, but just knowing cochlear implants work. You can do better than you're doing in your hearing aids, and I, encourage you to, think about it and learn more. What are your thoughts on this? Do you know any? Just getting that conversation started with them. Your patients really rely on your recommendations, and they do. Yeah, go ahead.
I was just curious how it relates to tinnitus. Do they, hearing aids being able to mask or phase cancel, but with implants, do you get any better results for tinnitus?
Thank you for bringing that up, because, especially for patients with SSD, tinnitus can often be a significant component of their struggle. And, even with traditional CI candidates and users, they may have tinnitus going into it. And what we do see is a lot of benefit, for most patients with tinnitus. When they take it off at night, it may still be there. It might get worse, of course. But while we can't promise that tinnitus will go away for every person, so I think that, it is important to have a conversation of, yes, we do see this for a majority of patients. Some patients do experience, an increase or an appearance of tinnitus right after surgery that should resolve. But again, yeah, and that's where adding in those measures like a THI questionnaire and being able to, think about that as part of your process can help in getting that information. But yeah, we do see a lot of tinnitus reduction suppression with CI. And I think that's one of the benefits when you look at CI versus those other treatment options to like a bone conduction or a cross hearing aid. Because you are actually getting the stimulation to that specific nerve rather than sending everything over to the other side. So again, we've been talking, throughout the last, day so far about helping give patients the information to decide their own path. So, we're going to give them as much information as we can to let them go forward as they need. And what you say and how you say it really matters. So instead of, how many times do I have to tell you there's nothing more I can do for you, saying, I know you're hoping for a new ear mold today, but I think it's time that we consider the next step of cochlear implant. And when we think about, how can we say that? Everything has been done to maximize your hearing with hearing aids, and a cochlear implant may be the next step in improved hearing. The more we can help focus them on what do they want, what are their hearing goals? Doing a cozy, whether you're doing it informally, but if you can formally assess what are those goals and have that baseline to go back to and say, there are a percentage of patients who have what we call decisional regret. And what's interesting is there was a study done on decisional regret for cochlear implant patients, and their performance didn't necessarily determine their satisfaction or decisional regret, but it was really more about their expectations going in. So that importance of aligning with the patient, understanding their expectations, establishing realistic expectations, and really helping them understand what their role is in achieving their goals and expectations will be important. It's a partnership, and it shouldn't just be the provider telling the patient, here's what you need to do, this is going to be best for you. It's really more of a joint venture together with them. Again, if somebody is hesitant, probing, leading with curiosity and finding out more, tell me about that, and learning. Is it because, they just have a general fear of surgery? Do they think it's going to be this long drawn? Do they think it's brain surgery? It's not brain surgery. And, Dr. Mahubi's excellent talk last night, I know he was really focused on those middle ear pathologies. He's an excellent cochlear implant surgeon, and that's definitely not one of the more complex procedures that he or other neuro-otologists do. So I think that can also help put patients at ease to understand that it is so well established, and they are doing much more complex, including, where they are really getting into that brain area, but not with cochlear implants, and certainly not with bone conduction either. These are low pain recovery surgeries.
We don't deal with cochlear implant patients, but obviously we refer. And as you just said, you want it to be a joint effort. They come to us, they've been coming to us for years, they like us, do you have a counseling packet so I could go over it with them? Because I'm not always up to date, to be honest with you, with the latest criteria, et cetera. And then have a contact person in the packet that they can, and I can say, hey, I know this person or whatever, so they feel more comfortable about it. Rather than just, hey, just go pass on to, go call house or go whatever.
I can't believe you teed me up like that to talk about the resources. Thank you. Thank you. So the question is, what kind of resources do we have to, enhance your counseling and help you have that information to refer to? I certainly do not expect you to leave here remembering those numbers and exactly what to say, but we have a lot of resources. We've got some resources here today that can help go along with that counseling. I'm going to work with Kathy to provide digital resources for all of our online friends today, too. So then, when you see what you like, we can get those ordered for you. My colleague, Jamie Tanahana, her whole role. So while I'm really focused on working with CI centers, surgeons and audiologists that are already working with cochlear implants, what Jamie does is she works with those private practices who are not working directly with cochlear implants, but are looking to maybe develop a relationship with a CI center for that referral relationship, helping to set you up with all those resources and confident counseling. And, we're going to get to that too, where we can see, and again, we've got folks on our teams that their whole job is to connect with those patients, help them connect to a recipient that can share their experience story, help answer patients' questions, and give them really that more personal perspective. One thing that you can do, when you can overlay that patient's aided sound field audiogram with what an expected cochlear implant aided sound field audiogram is, you're really, that can be compelling to help them understand how much more access to hearing that they'll have, and then what does that mean? How does that translate to the different situations that they are in? And then again, be able to share some of that outcome data with them to help them gain confidence. So again, you don't want to say that the CI is the last resort, but we want to say that it's the next step. And we don't want to assume that patients are too old, or that we don't want to put barriers on them. That's really for them to understand, decide for themselves, and determine with the help of their CI evaluation. Don't wait until you're totally sure that they're a candidate. Worst case scenario, if they're evaluated and they're not yet a candidate, they've started that process, they have more information to go on. It'll help them down the road. And again, maybe they're going to come back to you and it's time for some new hearing aids, and just thinking about, they've got to add a remote microphone right now, and think about what other strategies they can use to improve their hearing aid performance. And when we document that candidacy in their EMR, or in your, I'm going to move forward here just a second. When we document it in either their chart, the EMR, what we see is that there's a greater likelihood that conversation is going to continue at future appointments too. It's often not going to be one conversation, and if that can happen with more of the professionals in their care sphere, that's going to be great as well. We want to make sure that when you do have those partnerships with a CI center, that you get those patients back to fit the hearing aids. CI centers really do want to partner with you and make sure that they're sending those patients back to you when they need the hearing aids. They want that. That could be a bi-directional referral system. And when you have a patient that may not have been as open to new hearing aids, because sometimes they can think, oh, you guys just want to sell me more hearing aids. When they hear that recommendation from somebody who is not a part of their hearing aid care and isn't going to benefit from the sale, like that cochlear implant surgeon or that other professional, that may be a greater motivation for them to consider those new hearing aids and understand that your recommendations were really coming from the best place possible. And the vast majority of patients do continue to wear a hearing aid on their other ear. They're bimodal. So I think it's about 70% of patients. So they're often still going to need you for that hearing aid fitting, and they'll continue to be part of, you're part of their lives, and you still got that trusted relationship. Yes?
Does Medicaid cover for older people, in terms of Medi-Medi people?
Like Medi-Medi, oh yeah, so Medi-Cal, Medi-Medi absolutely covers cochlear implant, yes. Yes. Yeah, I wasn't quite at the...
Online people can't hear.
No, that's why I was trying to make sure that I'm repeating what the, question or topic is, and then I give the answer, so... I'm almost. Yeah, actually, so essentially, so make sure, we've got those 60/60 resources. And again, not only are you thinking about what are those numbers, but there are questions on that 60/60, whether it's a magnet or a placard, questions that you can think about for your patient to see, are they struggling to hear on the phone, or are they able to talk on the phone? Are they having those struggles and noise? Because again, they're much more than the numbers, and it may be that when we ask those questions, it gives us that additional information to help know the kind of conversation to have with them and getting them to move forward, document that candidacy. And so one thing you can all do as those non-CI providers, you can email Jamie Tanahana. So Jamie's in the back right now. She's got that fabulous cochlear yellow blazer on, and actually everybody knows Jamie anyway, right? So Jamie is a great resource. If you and I have gone way back, I'm always happy to be an additional resource too, and help get to those connections and resources that we need. We want to get that follow-up education, and if you aren't already connected with a center, a CI center, a CI surgeon, that's something we can certainly help facilitate that relationship. And, we really see lots of openness in those kinds of partnerships. So, and then what can we all do better? CI programs are partnering, with audiologists in private practices to provide some cochlear implant services. So especially for those patients who are out, geographically farther from a CI center, that's removing another barrier to care, keeping that care within your own practice. So that's been a great way to expand, more ways that we can all collaborate together. Because I think we all do have those same shared goals, essentially. Embracing telehealth options with remote care options now, this is a great way. And you see, Nancy is an older person who is utilizing technology. She's using her app. She's direct streaming on the phone. If you're patient, you can ask them, what kind of a phone do you have? And, what do you do with it? If they do anything besides making a regular phone call, if they do FaceTime, if they get on Facebook, that's savvy enough, and they'll be able to learn this technology very, very easily. And we've got the support resources to do it. And then having this standard of care that we're all following. So, CI programs embracing and implementing the new MSTB3 so that we're all, aligned together. For those of you who are working with CI, we do have an updated clinical protocol, lots of other resources here, so that QR code not only is available now, but in that follow-up slides, it'll be there so you can grab it later too as well. And earlier referrals are going to be really that key. And I'm going to, there's one more video at the end, but in the sake of time, I'm going to go ahead and get to questions. But there's a triathlete who getting implanted got her back to competing in all of these, sports that she loves so much, and helping her stay safe while she's doing all those too. So I love to continue hearing stories of patients that are, doing great. And again, these aren't outliers, but they're just, some examples of what's possible. Thank you so much. And I'd love to take any questions.
Okay, I'm going to be selfish and take the first two questions. I'm kind of going back to the early part of your lecture. Are there studies that have compared cochlear implant users who are adults with acquired progressive hearing loss versus adults who were born deaf and then decided to try cochlear implants?
That's something that, if I make a note of it, I can have we have a staff librarian that I can ask to look up studies on things, since I don't always, have the ability to do that. So I can look at that. I know that a lot of the studies that, that are done on adults are, adults who had that just progression over time.
Right.
Certainly, realistically, the outcomes for somebody that's had that profound loss from birth compared to an adult who, reached that in their 50s, 60s is definitely going to be a different conversation, different story. But what we do see, I think we do see more and more patients who are adults who have had that deafness from early on and choose to get a cochlear implant later on. Mm-hmm. Maybe they want that sound awareness for, they've had a baby, or there's, another reason they want some additional sound awareness. There was a patient that I was connected with last year who was, did fall in this category, had gotten an implant earlier on, but then had abandoned it years prior. And he decided he wanted to try it again because he wanted to hear his dog. He wanted to hear his dog bark. Okay. And, that's a very realistic expectation. Mm-hmm. And he was thrilled. It was, a great experience. So, again, aligning to realistic expectations, I think, is going to be crucial. But I can make a note and definitely look into that for you.
And my second question is, you were talking about educating the patients and everything. Because I'm an educational audiologist, I have to deal with parents a lot. And a lot of parents always ask me, well, how do things actually sound through a cochlear implant? And I realize that everybody is going to hear differently through a cochlear implant, but is there some sort of resource you could recommend?
That's been, the examples that we've had historically to share that have been available have, I think they're very outdated.
Yes.
And not realistic. The best example that I heard at CAA several years ago, there was a CI recipient who, I think he was SSD, and he was able to, I think he was an engineer.
I know what you're talking about. It's a YouTube video.
And he made that.
It's actually a girl.
Oh.
And she's single-sided deafness, and then they put an implant in, and they had her compare one side to the other. Is that one the one you're talking about?
Different, but yeah, I know about that one.
Okay.
Thank you for bringing that one up as well. So I think that's, probably the best resource I know of, unless Alicia or Stacy, do you know of any other new ones that I just haven't been aware of? Okay.
No?
Yeah, so I do think it's important to help them understand that, yeah, everybody hears differently. And even when we think about music perception does not depend on the specific device that somebody gets, but it's much more about their own individual, etiologies, different factors, their brain. Were they previously a musician? They come from a family of musicians. You saw Nancy's experience. I know other people who have that experience. I know other people who, have a harder time with music. And so, again, it can be variable and have different factors.
Anybody else have a question?
Yes.
I'm going to give you the mic. There you go.
Thank you. First of all, compliments. That was an excellent presentation.
Thank you.
I think implants are unbelievably amazing. They change people's lives so dramatically. So I think it's great that you're doing what you're doing. Obviously, as you pointed out, the strict guidelines have become much more liberal, which is great to see. But obviously, there are stumbling blocks for people making that decision to get an implant. As you talk, health reasons, you're going through surgery. One of the other things, I think, is cosmetics. And obviously, if you have a really profound hearing loss, that should be secondary. But as the guidelines loosen up a bit, and you have people with these moderate hearing losses or moderate to severe with not the worst discrimination scores, but not great discrimination scores, cosmetics may become more of an issue for at least some people to consider. And I understand Envoy is just kind of doing their studies with the Claim, which is the totally implantable cochlear implant, which I would imagine is every cochlear implants company's goal is to have an implantable. I was just curious what your thoughts were on that and where Cochlear is in that process.
That's certainly been something that Cochlear has been working on for. One thing I love about Cochlear is that they put the most of their revenue back into research and development of in the industry, and that's certainly been a topic of interest for many years. I personally haven't seen where they are and what that looks like currently, but I know, yeah, it's. When are we going to see it in place? That's a great question. But you're right, because I was talking to one of my CI audiology buddies yesterday, and he was sharing that he just run into that think about some of our patients in kind of those VIP wealthy areas where there's a really big maybe concern about stigma. How will they be? How will that impact how people see them? And that it does continue to be a question, and hopefully, there are, depending on, how much hair you have, and, there's so many ways that at this point, the Nucleus 8 is, getting more comparable to like a power BTE. That's still a cosmetic challenge for people too. Having an off-ear processor that can, again, kind of be a little more discreet, and sometimes so that can help people come along. I do think there are people who are still feeling more headstrong about that's still all too much. That's always hard for me, thinking about those of us that have been doing cochlear implants for a very long time, when they were like a box with a long wire or, much bigger devices. They're getting smaller, more comfortable every generation. So, hopefully the more that we can show them, let them try it on, look, that will be there. And again, not only things like a totally implantable, but there's a lot of research being done, for how do we have better hearing preservation, better, long-term outcomes, because you're looking to maintain and improve cochlea health over the long term and reduce, the inflammation, that inflammatory responses that can happen with implants or, other impacts. So yeah, I think we're working on it. I mean, we still have to get to the fact. I listened to one of my favorite podcasters yesterday, and she was talking about how she, doesn't want to wear hearing aids that she desperately needs because she's like, I'm only 50, and I'm like, girl, you got to stop, thinking about, hearing aids as being something for old people or cochlear implants being for a certain age group. Why do we still consider hearing in such a different category? I mean, look at how many of us in the room are wearing glasses. Like, why is it not equal? It's so frustrating. But yeah, thank you.
Thank you.
Anything else?
Are there any online questions? Okay.
Is the question, when is she going to stop talking?
No. So this is a question in regards with continuity of care. They're asking, do you feel like it's best for a bimodal patient to have services with the CI audiologist if they are familiar with a hearing aid manufacturer?
Oh, hold on. Let me make sure I understand. Can you say that last part again? Because hearing aid manufacturer or hearing aid provider?
They said hearing aid ear manufacturer.
Oh, okay. So, if we're thinking about a bimodal patient, so somebody's going to be considering an implant and they're going to continue wearing a hearing aid, one thing that is strongly recommended is that they really focus on the ear that's going to be implanted and not their current hearing aid and hearing aid manufacturer, no matter what that is. There are lots of great hearing aids out there, and no matter what kind of partnership we might have as implant manufacturers with a hearing aid manufacturer, at the end of the day, the patient should be thinking about the implant that's going to be in their head for the rest of their life, right? Because for many patients, while they may even start as bimodal, you may see many of them go on to become bilateral cochlear implant recipients later on. And there are a lot of differences between hearing aids and cochlear implants, and the way that they may get support. There's the way that the external technology may fit with their lifestyle, the way that the different electrodes and internal implants may have different benefits for their particular etiology. So, while they may have loved their, whatever that hearing aid is, it doesn't mean that they should only consider that manufacturer that is paired. They really should do the extra research into their implant choices.
For that bimodal, doesn't there have to be the hearing aid ear, a particular device or manufacturer, to be able to be compatible so that it can utilize streaming functions, and don't they have to?
Yeah, so if they do, so certainly, currently, like Cochlear partners with Resound, we have, and within Resound's portfolio, there are multiple options for compatible hearing aids and styles, depending on, again, their need and what they're looking for, whether they want rechargeable or, disposable batteries. So, even if they came in with a Resound, it doesn't necessarily mean that they already have that Resound that's compatible with their device or is linkable. And same thing for considering a different manufacturer and they're partnered, when we look at what's that compatible device, it may not be the hearing aid that they're currently wearing. And, I've certainly also seen where patients have made those choices because of the partnership, and then they learned that they still had to get a different hearing aid than what they were wearing, and they didn't always, weren't always as happy as they were with their previous. So, there's just a lot to consider, and if they're going to have the hearing aid that they came in with for another year or two until it's time to upgrade, that's not the end of the world. certainly people can wear any hearing aid on the other side and get lots of benefits. The additional benefits, of course, are going to be bimodal streaming, whether to accessories, to the phone, if they have bimodal control of both devices from one app. So, there's those things to consider, but it doesn't mean that they won't get benefits of just general bimodal hearing. These are really fantastic questions. I love it. And feel free also, as more questions come to you, to come talk with us over lunch and through the day as well. With the follow-up too, I will say, just for anybody working with bone conduction in pediatrics, there are going to be some upcoming patient education event opportunities. My colleague Carla Sanchez-Cabañas, who is Spanish-English bilingual, she is offering a couple of sessions on January 15th and 16th, so I'll make sure that information is included. These will be virtual sessions at 6 o'clock with, one in English, one in Spanish, the one night and the next night, so that families of pediatrics in a non-surgical bone conduction system can learn more about surgical systems, that process, and again, what are those benefits and how can they make sure that their kids have the best access to hearing for their needs.